A mother complains. Since several weeks, my 14-year-old son is locking himself in the bathroom and showering there for hours. If I knock on the door and ask him to come out, he gets angry. I feel completely helpless in this situation. The father reports, my 9-year-old daughter confessed to me in tears that she has to say the numbers from 1 to 10 backwards for hours. If she tries to top this, she gets scared that something bad might happen to us, her parents. My wife and I are now wondering whether we did something wrong in bringing up our child. These are two examples how parents reported about children with obsessive-compulsive disorder, OCD, who they presented in my practice. It became clear to me again and again that these children and their parents suffered greatly. A particular problem for those affected is that the execution of the obsessions and compulsions is very time-consuming. In severe cases, those affected are busy with them for many hours a day. The following video from Good Parents describes the symptoms and causes, but above all, the treatment of this disorder, which is not rare in childhood. Hello, I warmly welcome you to Good Parents. My name is Wolfgang Hirschberg. I am a specialist in child and adolescent psychiatry and psychotherapy. In the past years, I've often treated children and adolescents with obsessive-compulsive disorder. I have therefore dealt very thoroughly with diagnostics and therapy of this disorder. The experiences that I have made have been incorporated into the following video. Obsessive-compulsive disorder in children and adolescents mostly begins around the age of 7 to 12 years. With regard to the symptoms, a distinction is made between obsessions and compulsions. Obsessive-compulsive thoughts and actions very often occur together. According to the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, obsessions are, I quote, recurrent and persistent thoughts, urges or images that are experienced as intrusive and unwanted, whereas compulsions are repetitive behaviors or mental acts that an individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. Examples of compulsions are washing compulsions, in which the person concerned has to wash their hands again and again or to shower for a long time, or control compulsions, in which the persons concerned have to make sure again and again, for example, that they switched off the light or the stove. Examples of obsessions are counting obsessions, in which a certain sequence of numbers has to be repeated over and over again. Another form of obsessions are obsessive thoughts with aggressive content, e.g. the thought that the person concerned could attack a close person or could show sexual aggressions. The obsessions and compulsion among OCD are, in contrast to these symptoms in psychosis, experienced as own thoughts. Mostly, however, they are not perceived as belonging to one's own person or self, but rather as senseless and exaggerated. It is also said that the obsessions and compulsions are foreign or dystonic to the self. Those affected therefore report about them as follows: I do not want to think this thought or to perform this action, but I have to do it anyway. Many affected resist carrying out the thought or action. Then, however, fear arises that something bad could happen to the child or its relatives. The affected persons get into such a strong state of tension that they give up their resistance and carry out the acts or thoughts. This initially leads to a relief or relaxation before the urge to carry out the compulsive actions or thoughts manifests itself again. However, younger children often have little or no insight that their behavior is excessive and senseless. Also, if the symptoms exist for a long time, the feeling of meaninglessness can be lost. Because of the uniformity with which the obsessions and compulsions have to be carried out, they are reminiscent of rituals, as can be observed in different areas of life. Especially children need such rituals. They give them security and the feeling that their world is in order. A typical example of this is the go-to-bed ritual, which helps the child to separate from its parents in the evening and to stay alone in the room. Such rituals are no compulsions, but rather represent a completely normal behavior, especially among smaller children. Through a ritual, in contrast to a compulsion, the child's life is not impaired, but rather stabilized. OCD often occurs together with other mental disorders, especially anxiety disorder, social phobia, depressive disorder, tic disorder, as well as attention deficit and hyperactivity disorder, ADHD. In addition, other mental disorders that can also show obsessions and compulsions, respectively, must be excluded as part of the differential diagnostics. These include hypochondriac disorder as well as schizophrenic disorder and body dysmorphic disorder. Various neurological disorders as well as some drugs can also lead to the appearance of symptoms of OCD. According to scientific studies, genetic factors are involved in the development of OCD. Neurobiological factors also play a role. The areas of the brain in which the transmission of stimuli takes place with the help of the messenger substance serotonin are apparently particularly affected. This assumption is supported by the fact that substances that intervene in the serotonin metabolism of the brain often lead to an improvement in the symptoms of OCD. Of course, psychological factors are also involved in the development of OCD. However, it is often not easy to find out which emotional causes have obsessions and compulsions among children or adolescents. It is noticeable that the children or adolescents concerned are often very conscientious and therefore quickly fear that they have done something wrong. The compulsion, e.g. to wash one's hands, can mean in a symbolic, figurative sense, I wash my hands in innocence, that is, I have done nothing wrong or bad. The compulsion to wash can be understood here as a magical ritual with which the persons concerned have to demonstrate their innocence. In male adolescents with OCD, it is often noticeable that they cannot cope with their developing sexuality and the physical changes that go with it. E.g., the normal ejaculations during puberty are experienced as defilement. The shower then represents an attempt to remove this contamination, but unfortunately this does not succeed, so a shower compulsion that takes more and more time develops. The parents of the affected children or adolescents often ask themselves whether they did something wrong in the upbringing of the child or adolescents, which could then be the cause of OCD among this child. It can be said that mistakes in parenting are almost never the cause of OCD. It is noticeable, however, that in the family of children with OCD, great importance is often attached to virtues such as accuracy, neatness, or cleanliness. It is also noticeable that in many families of patients with OCD, the self-control of negative emotions such as anger, disappointment, or rage is very important. However, the children or adolescents affected are often unable to achieve what is required of them in this respect. The compulsive actions must then be seen as a futile attempt to meet the requirements of e.g. order, cleanliness, or self-control. If you suspect that your child has OCD, you should see a child and adolescent psychiatrist or child psychotherapist as soon as possible. If the professional diagnostics confirms the presence of OCD, a psychotherapy must definitively be started. It may not be easy for you or a child to accept this. However, experience has shown that without psychotherapy, there's little chance of improvement in OCD. On the contrary, the longer the start of psychotherapy is delayed, the more difficult it is to treat the disorder afterwards. This means that there is a strong correlation between the duration of a disorder at the start of therapy and the success of the treatment. The psychotherapeutic method that has proved most effective is cognitive behavioral therapy, CBT. In the course of the therapy, a change in attitude of the children or adolescents concerned must be achieved. They shall learn to be more generous towards themselves, that is, to accept their mistakes or other insufficiencies. If adolescent patients have problems with their physical and emotional changes caused by puberty, they should learn in the course of therapy to accept them. In particular, the adolescents should realize that their newly awakened sexual desires and needs are something completely normal and by no means something dirty or even sinful. As part of the therapy, the question should also be investigated which situations trigger the obsessions and/or compulsions. For example, touching a door handle that is perceived as contaminated with bacteria can trigger a washing compulsion. Likewise, the sight of a stove top that might not be switched off can trigger a control compulsion. An effective therapy can then consist in confronting the affected child or adolescent with these situations. The children or adolescents with OCD are encouraged to experience these situations without performing the compulsions. In this way, they should learn that the feared consequences, e.g. an illness or a fire, do not occur. Another therapeutic approach is that those affected learn to distract themselves from their obsessions and/or compulsions by thinking of contents that they experience as pleasant and not burdensome. In addition, many children and adolescents with OCD have to change the way they lead their lives. They should experience that life does not only consist of duties, orderliness, and other virtues, but that a good life, especially in children and adolescents, also includes play, fun, and joy. Of course, the family of the affected child or adolescents must also be included in the therapy. After what has been said about OCD so far in this video, it should be clear that compulsions are not being performed intentionally by your child, e.g. to annoy or provoke you. Also, please note that you are not helping your child if you are assisting in any way in the performance of compulsive rituals. Sometimes it is rather necessary that, in consultation with a psychotherapist, a compulsive act is interrupted if the child is unable to do so in its own. This can be the case, for example, with washing compulsions. In addition, you should ask yourself to what extent you can allow yourself and your child to express emotions spontaneously, and to what extent you expect too high a degree of self-control, accuracy, and needliness, as well as similar virtues from your child. With pronounced obsessions or compulsions, drug therapy is sometimes required in addition to psychotherapy. In particular, substances are used that intervene in the serotonin metabolism of the brain by blocking the reabsorption of the messenger substance serotonin from the synaptic gap. Inpatient therapy may be necessary if the symptoms of OCD are very severe and an intense therapy is necessary. In the course of inpatient therapy, further therapy offers can be made to the child, especially in the sense of creative therapies, e.g. painting therapy, music therapy, or motor therapy. With the help of the therapy measures mentioned, a significant improvement in symptoms can be achieved in many children and adolescents with OCD. However, in some cases, one has to accept that a complete elimination of the symptoms is not possible. But even then, it is usually possible to stabilize the psychic state of the children or adolescents concerned in such a way that they can cope with their everyday life, e.g. in terms of school attendance. That's what I wanted to say today about OCD among children and adolescents. I hope that you liked it, and above all that I could give you some useful information about OCD among children and adolescents. If this is the case, I would be glad if you could give me a like. For today I say goodbye, I wish you all the best, and until soon, goodbye.